but I thought it might be really interesting for everyone to start off with those who are age 15 or 16 first, rather than necessarily having the teenage members of the panel wait to the very end, maybe to go first. So I'm going to introduce Rajan Laddu. And Rajan, you participated in our pre-meeting yesterday, so I got a chance to know you. Your parents are here, and I see your grandfather. I don't know if grandma stepped out of the room, but why don't you have your parents and your, at least grandpa and grandma, if they're here, stand up so we can just acknowledge you. That's grandma's back toward the back of the there. And I was struck when we chatted really how articulate you are, and maybe you could tell us briefly your story. And part of what we'd like you to do is give those of us who are clinicians some clues on how we can better serve patients.
Hi, so I'm Rajan, as he said. So on May 19th of this year, I went into surgery for a spinal fusion because I had scoliosis. At first, I was just worried about the amount of pain I would have and the recovery time, but little did I know that something else was lurking about. So the surgery went fine. My doctor was pleased with the results. But the day after, I was lying on the hospital bed. My friends were visiting, and all of a sudden I started feeling this really unpleasant sensation. My chest was hurting really badly. I had shortness of breath. My heart rate went up to 140 beats per minute, and my oxygen saturation went down from 100% to 79%. And I was saying, I can't breathe, I can't breathe. My mom was like, what's happening? And my dad was shaking his head and saying he's having a pulmonary embolism. So the nurses were called in, and I was put on oxygen, and I was taken to go get a CAT scan where it was revealed that I had a large bilateral PE. So I was immediately taken to the intensive care unit. And the next day, it seemed like almost all the doctors in Central Florida had come together and were discussing what to do, since a case like this is very rare. What it was finally decided was that they would insert a unique catheter with these ultrasound crystals at the end, one into each of my pulmonary arteries, and these ultrasound crystals, they broke up the clot, and then they inserted a small amount of medicine called TPA to basically dissolve the clot. Miraculously, 98% of the clot had been removed. I'm doing a lot better now. I'm actually on Lovenox shots just for a precaution, but I'm very grateful to be here. I'm grateful for all the doctors who contributed to helping me, and I hope that I can be able to help others so that they don't have to experience what I experienced. And that now I'm back in school. I'm a junior in high school in the International Baccalaureate program at Windermere Preparatory School in Windermere, Florida, and recently I just got back my progress report with all A's.
Well, that's great. I think there is this misconception that pulmonary embolism is an illness of the elderly, but nothing could be further from the truth. And I believe that pulmonary embolism has been missed as a diagnosis in many who are your age, Rajan, and younger, because when you go to medical school, you're not taught that pulmonary embolism can strike teenagers and preteens. And I think it was really a testimony to the skill of your physicians and your healthcare team, you know, the nurses, everyone else caring for you, that they made the diagnosis of pulmonary embolism. I'm sure that you were the youngest pulmonary embolism patient they had ever treated or seen. And I think that's another message for us at NATF, that we have to make it clear when it comes to pulmonary embolism, it can strike at any age. So, Caitlin, do you want to tell us a little thumb summary of your situation?
Surely. Hi, everyone. My name is Caitlin Augustine. I've been involved with NATF for several years now. Luckily, I never had a pulmonary embolism, thank God, but when I was 18 years old, they did discover, I think it was 3 or 4 massive DVTs in my leg and abdomen that went misdiagnosed for about 10 years. I was having symptoms all along. I had plenty of risk factors for basically my entire life. The symptoms started around when I was 12 years old, but was misdiagnosed as ovarian pains, and I was put on birth control, which of course we all know makes clots a lot worse. And they didn't actually discover it until I was a freshman in college. I had a routine tonsillectomy. I was recovering at home, and I started experiencing some abdominal pain that eventually radiated to my leg, but nothing that doctors were concerned about. They said it was probably sciatica. I was sent home for the weekend, and next thing I knew, I couldn't move. The symptoms got a lot worse until they finally, after 10 years, diagnosed me with the DVTs. My prognosis was not good. They told my family I wouldn't survive, but 10 days later they sent me home, and I went back to school, and ever since I've been trying to advocate for young people just like you. And I just want to thank you and your family for being here and spreading the word. It's really amazing what you're doing. You're taking such a negative thing and turning it into something very positive. So, and I can't believe you're 16. You're going to do great things, so keep up the good work.
So Caitlin, how old were you when the diagnosis was first made?
18.
18, okay. Charles, do you want to give us a little thumbnail sketch of your experience with venous thromboembolism?
I will, and if I may, can I give you some comments?
Of course.
From observing this?
Of course.
I would put myself in the classification of the sort of sophisticated patient, as I think the keynote speaker was, and I think that young nurse who spoke today. I'm a lawyer. I represent thousands of disabled people, so when I had my blood clot, I thought I had a blood clot. At least I thought it was a possibility. I had had laparoscopic appendectomy 2 weeks earlier, and I assumed that when my leg swelled up massively and I couldn't put weight on it, that I was at least a possibility of having a blood clot. And my experience wasn't so hot because I went to the emergency room, and of course the nurse said to me, "You have a blood clot," which didn't make me feel good because I knew what that meant. But I saw the emergency room doctor who said I had a hamstring pull and sent me home. And the following day I saw my internist, board certified, Columbia University Medical School, who said, "Yes, you have a hamstring pull." And while this was going on, because I do have a lot of friends of mine who are doctors who heard my story, one of them, a retired gastroenterologist, called my internist and said, basically, "You're crazy. He just had surgery. His leg swells up massively. He can't put any weight on it. And you're saying it's a hamstring pull? It's a blood clot." And actually, it was not a very pleasant conversation because my doctor told me about it. He then sent me to an orthopedist. So this is approximately 36 hours after I first got diagnosed, because I'd gone to the emergency room first, sent home, saw him first thing in the morning, and now I'm seeing the orthopedist. And the orthopedist also said, "Well, I don't know what it is. It's not a hamstring pull, but everyone else has ruled it. They say it is, so it must be. I don't know what to do, so I'm sending you back to the internist." And I went back to the internist, and again, my friend called and said, "You better have an MRI done. That's the only way I'll convince you it's a blood clot." And he reluctantly agreed to do this. And I then had the MRI. I was the last patient of the day because it was a non-emergency because it was only a hamstring pull. And I swear that the radiologist came out shaken and said, well, you have massive blood clots in your leg. You can't even walk across the street to the hospital. I'm going to walk you, I'm going to put you in a wheelchair and carry you, and you have to get a cab to circle the block so you can go to the emergency room. And of course, as I walked into the emergency room, I saw the same nurse who said, I told you I had a blood clot. I don't mean to make it sound so awful, because I then switched, against medical advice, I switched hospitals and got the most amazing treatment, including TPA at Cornell. So I'm alive, which I guess has disappointed some of my friends who are lawyers, because I thought a great malpractice suit was there, and they could break the records for most money ever awarded against the hospital. But the one thing I thought about in hearing this conversation is that everyone here is very sophisticated. Most of my clients are poor. Many of them are rural. They wouldn't know what a blood clot was if you yelled it out to them and planted on them. And I thought about how little knowledge they have about what to do if it happened. If so many bad things can happen to sophisticated doctors and people like me, what happens to somebody who is a 10th grade education illiterate in Kentucky, where the quality of care is not going to be as good, where it's a rural clinic? What are we doing about those sort of patients? And I was trying to compare it to things like the Heimlich maneuver. Everybody knows what that is. If you were in the north end of Boston and you were eating calamari, which I'm told is the leading cause of Heimlich maneuvers in Boston, somebody in the restaurant would know what to do. Really, somebody would know. The wait staff would know, the owners would know, or more likely, there's going to be some fireman in the restaurant who's going to know exactly what to do. And this should be no surprise in Boston, because I don't think, Dr. Goldhaber, you know this, but there was a recent article, 2 recent articles in the New York papers about that there were more Heimlich maneuvers done in Boston than any other city per capita. And then the second article, though, came out that it was a mistake, that it was all biased by the report, because apparently one person in Boston has been doing 25 or 30 every day for the last month, and that turned out to be the trainer of the Boston Red Sox. Spoken like a true Yankee fan. But I thought about people going into surgery, and I have lots of friends and clients who call me, and they're having hip replacements or knee replacements. And when they go into the hospital, every patient is forced to sign a medical release, which they don't read, and if they did read, wouldn't understand, saying basically you've been told of the risks. But when they leave the hospital, what do they get that tells them, gee, there's a possibility of a risk of a clot? This is what you do if you get it. I had minor surgery not long ago. I had a lipoma, and because of my history, it was not minor. I'm in the hospital for it. But when I left, no one said a word. Now, my doctor has told me that I will never have to worry about this personally, because I will know what the symptoms are of a blood clot. I guess that's true. But I'm thinking, if I didn't get any notice, what about these people getting hip surgeries and knee surgeries where there's a real risk? Are they being told what the symptoms are so that they know and what to do? And how hard would that be to create some sort of a pamphlet that would tell them that? And I suggest that we all think that we'll give them a CD of, this is what it is and all the rest, but based on my experience, we've done studies on my clients, and 70% of them really don't use the internet. And my clients are basically 45 and older, and 30% are sophisticated and love this sort of CD and will be on the internet, will check out websites. But 70% are basically still on paper and pen and would not do that. So I really would suggest it should be some sort of a pamphlet that's really, in no offense, dumbed down language that tells them what it is. I thought one thing I really like today is, I thought this is a terrific idea, is this, if I can get it out of my pocket, this luggage tag. I mean, this is a terrific thing to have, which tells you that this is what you do for DVT. You drink plenty of water, you get up and walk about, you exercise with your toes during the flight. This is really a terrific idea. I don't know whose idea this was, but this is great. There should be something like this, simple to read, easy to carry, that should be given to patients when they leave a hospital after, I wouldn't say merely major surgery, every surgery, and say, gee, here are the symptoms of a blood clot, here's what it means, here's what you do if you think you have those symptoms. That would be terrific. In my world, when we can't get something, we do what we call deputizing the client. You would call deputizing the patient. Get them involved in their own, my case, their own case, but in their own care. Tell them, gee, this is something you need to know. This is really important to you. I have found, and this surprised me, how seriously my clients take this. They really take their role, if you call them the deputy, they really take their role seriously. They really try to help them on their own case. They're very, very interested. I think the same result would happen if we could come up with some very simple, easy to read, some memorable thing like this, that post-surgery they would say, I'm taking this home with me, I'm going to put it where my spouse and I can look at it to make sure that if I start having these symptoms, I know what to do.
I think those are great suggestions, and it's quite scary hearing the way you were shunted back and forth, because you know, my impression of Manhattan medicine is that something like that wouldn't or could not happen, but it's humbling to hear. So thank you for sharing that. Ted, do you want to tell us a bit about you and your situation?
Sure. Well, first of all, Dr. Goldhaber, thank you for the excellent care. I am a patient of Dr. Goldhaber, and we found him in some mysterious ways, but we were very, very lucky. So thank you, and thank you for inviting me. I was diagnosed with a pulmonary emboli, meaning I had several of them at age 49. I fly 125 to 175,000 miles a year. I'm not sure immobility is completely the issue here, but it probably didn't help. The job is highly stressful, which probably does have a lot to do with it, but the one thing I wanted to focus on that I think has been a bit of a topic today is called denial. So I am very good at denying things like this, and I spent the better part of a week with increasing pain in the left side of my chest, increasing shortness of breath to the point where I had to sleep sitting up. And I was doing some very nasty stuff that week, i.e. laying people off that I was diagnosed, and by the end of the week I was in New York, I was walking to the office and basically walking probably at the pace of an 80-year-old, having heavy trouble breathing and immense pain. Got into the office, my human resources professional was there, and I told him that things were not going well. He said, go to the emergency room. I said, no, I have to do this nasty stuff first. Then I'm going to get on an airplane, fly to Boston, and then drive myself to the emergency room. And he looked at me as only he could, and he said, so you're scheduling your medical emergency today, Ted, right? And I said, that's exactly what I'm doing. So long story short, I went to the emergency room, and the problem was the pain had gone away, so I rated myself a 3 on a scale of 10 in pain. Earlier in the day, it had been a 10. So I waited 4 hours to get in, and then we went through the progression of the night, and they couldn't find out what was wrong with me until some blood test came in that was abnormal, and they sent me in for a dye-injected CT scan. And then, needless to say, the blood clots showed up. So, you know, one day into the hospital, of course, what's the thing you do when you get into the hospital? You try and find the quickest way out, right? So I said, how do I get out of here? And they said, well, first you have to inject yourself with Lovenox. I said, hand me the needle. Boom, now can I leave? And of course, they kept me around for a couple of days, and I had a lot of pleuresis associated with this. And when Dr. Goldhaber saw me, actually the lung was in pretty bad shape too, and I ended up going to a thoracic surgeon just for make sure that everything was okay on that end, which thankfully it was. But needless to say, we all have choices in life and how we're going to see the end of our life, and pulmonary emboli was not on my list of the way I was going to go. So the education here, the care, the quality of care has just been amazing, and I can't thank Dr. Goldhaber and his colleagues, particularly at the Brigham and Women Anticoagulation Unit, enough. I'm one of those self-testers, and I love the machine that I got, and I thank you for introducing me to that, too.
Great.
Thank you.
Ian, do you want to tell us about you?
Sure, and I'd like to make some observations, if I may.
Please.
To my left is an attorney who practices special needs. To my right is a judge. I'm an attorney who practices elder law and special needs. My quick survey has determined that the practice of law is indeed very hazardous to your health. Paul's keynote address struck home. how can someone who has that much knowledge, medical knowledge, not be able to convey to their medical people what's happening? And for those of us who are lay people, it's even scarier. My story is that I lucked out because even though I considered myself to be a computer geek and I constantly counsel my clients to be an advocate in their medical care, when my DVT and PE happened, I was completely helpless. I remember going into the hospital at night. I met a resident who told me that she would be my doctor, which was okay with me. In the morning, I opened up my eyes, and there were, in Paul's words, two angels in front of me. One was Sam, and the other was Ruth, and they were both wearing white coats. And Sam said to me, introduced himself to me and said, we're conducting a study. It's for 25 people. We only have 24. We need another one. And for some reason, and I don't know why I said it, I looked at Sam and I said, I bet you tell that to everyone. And he assured me that no, I was the 25th person. And he said, you know, I will hand you over to your primary after the 2-week study. And I'll be out of your life completely, and you'll go back to where you were. And again, I had the luck to be able to think quickly and say, I will participate in your study provided you don't cut me loose in 2 weeks, and you'll be my doctor forever. And he agreed. And that's a true story. As part of the Brigham Women support group, I really never thought of why I kept coming back to the group. I knew that I was comforted by it. I knew that I got something out of it, but being asked to be on this panel made me try to think a little bit more about it. And the way that what I've come up with is for this to work, this support group to work, it's really a three-pronged thing. And it has to start with the top. It has to start with the physician who creates the mood of being patient-friendly, of involving and involving the patient in the process. And it is that welcoming atmosphere that permeates down to all of the staff underneath him or her. And Sam provides that. Sam and Ruth provide that. I see them as, prong one, as being someone who has my back, who knows me more than just my patient number, who is a friend, who will help me when I need help. And I got to admit to you, because of that, I've become a really arrogant patient. If I have to go to the emergency ward, or if I am talking to a surgeon because I need a surgical procedure, I'm insisting that they call Sam. He says, no, I know about DVTs. No, I want you to call Sam. And it's good that I have that comfort as a layperson, that I know that this thing that I have that is life-threatening is being watched over. The second prong is having a coag unit. I'm a self-tester, and I call in every other week. And I have spoken to the same person for over 2 or 3 years, every other week, and we've developed a relationship where I feel that she is looking out for me also. Her name happens to be Gina Dubé. I told her that I would introduce her to the group. And even though I met Gina for the first time today, face to face, that's the second strand. That's the second prong. That makes me feel comfortable. And then the third prong is this support group. And there's 2 things that I get out of it. And the first is that the experts are coming every week, or every meeting. And Sam is there, and Ruth is there, and Catherine is there, and I can ask them questions, because there's only so much that the lay people can tell you. We can talk about how our PE happened, how our DVT happened, the history of it, how we're doing now, but questions come up, and it's comforting to know that the experts are in the room and a part of the group. And the second solace that I get out of these meetings is to see that I'm not the only one. And it's scary thinking, okay, I know these professionals, but what about everyone else? How do they react? How do they react to the fear that is created maybe 2 weeks after the event, when after people have been telling you all week long, oh, you had a PE. My druggist had a PE and he died. My accountant had a PE and he died. And you're thinking to yourself, yeah, I don't want to hear that. I didn't die, I'm alive. But when you're in bed and it's 2 weeks later and it's the middle of the night and you don't feel right, all of a sudden these things come back to haunt you. And so being able to share your emotions and your feelings with other patients who are in the same predicament as you are is very helpful. And so I think it's not only just having a behavior or a support group and thinking that that would be the success. You need to have a physician and a medical staff who is truly interested and wants to follow you and have that support, because that's the key, and that's what Sam and Ruth do so well. And again, I shouldn't have to be lucky in order to be in my position, but that's the way it is now. And hopefully through this organization, people won't have to be lucky. These services will be available to them because people know about it and they care about it.
Thank you, Ian. Jack?
Hi, my name is Jack Corbino, and Sam, I want to thank you for letting me follow two lawyers on this panel. I have been a patient of Sam's for 17 years and 10 months. I have been through 2 heart operations. I have a defibrillator. Most recently, I have a stent. And I cannot thank everybody here for their incredible support. And the fact that I'm probably alive today is because of Dr. Goldhaber and all you folks in this room and your commitment and dedication. It's amazing what I've been through medically, and yet I still pretty much function every day. I'm very active. I do all my calisthenics and exercising and stretching. I do all of the non-pharmacological things that are available. I test my own INR. I follow through with all the folks. And like my friend down here, I look forward to speaking with Sally every other week or so as we argue about how much asparagus, broccoli, and spinach I can eat. And I look forward to that, quite often. I've listened to everything that's been going on, today, and it's just amazing to me, the commitment and dedication and some of the thoughts and some of the ideas that have come out. The fact that the North American Thrombosis Foundation is a website, and I spend time on that. The fact that I get to talk with all the folks in Dr. Goldhaber's office quite often, and the fact that I feel secure. I had an incident walking around the quarries in Rockport, Massachusetts in May, and what happened was I fell over, my defibrillator went off. The cops came in. There was no way they could get me out of the woods, and this police officer took his patrol car, ran through the trees. They dragged me out, put me in an ambulance. A volunteer fireman carried our French bulldog out, and my wife, made it to her car, or our car, and I ended up after a couple of hours back at the Brigham with the wonderful care, and I just can't thank everybody enough. I haven't yet to have or experience a PE or DVT, and obviously it's because of the dedication here that has prevented me from seeing any of those issues. Education-wise, I absolutely know what to look for. I'm a student. I study everything. I ask questions. And the message that you folks are trying to get out today to other patients is fantastic. I love coming to these events. A lot of the information is way over my head, but the few things I do learn have been extraordinarily helpful in maintaining my health. And again, thank you, Dr. Goldhaber, and thank everybody here.
Thank you. I thought it would be useful to also hear from two of our panelists really the impact of cardiovascular disease and thrombosis on them and their family. And maybe we'll start with Carlos, if you want to talk about your personal experience or family experience with thrombosis.
Well, this is a really interesting memory. Well, my father was a cardiologist, and he had suddenly massive pulmonary embolism. When I contact the physician in charge by phone, I understand my father have a massive pulmonary embolism. And I told with him, why don't not thrombolysis? And physician in charge told me, no, because we don't have any evidence. And when he told me this answer, I have several reflections. First, thinking about thrombolysis in acute coronary syndrome, ST elevation, myocardial infarction, works in a small coronary thrombus. And I think, why not works in a big thrombus, more fibrin? Well, finally, my father died, and after this, we start interesting studies in my country using several thrombolysis regimens, specifically streptokinase, alteplase, in a small infusion, 1 hour. And this kind of regimens works in Mexican population, and today could be considered the most important regimens in several countries. Currently, we have an important network with more or less 25 or more hospitals. We are modifying in several patients with severe right ventricular dysfunction, the outcome, and many patients with more or less similar clinical characteristics than my father stay alive. So this is really my experience and how the evidence sometimes require a strong experience. And thank you.
Yeah. And I think it's fair to say you are in the forefront in Mexico of modifying and updating the Mexican guidelines for treatment of pulmonary embolism to incorporate a lot of the most modern evidence-based reasons for using thrombolytic therapy in massive pulmonary embolism. So in a sense, it's your father's legacy that pointed you in this direction. Very touching. Judge, do you want to talk about the impact of cardiovascular disease on the family?
Delighted to, Doctor. My story goes back, it's my wife's story in actuality. It goes back some 20, 25 years. It deals with strokes and stents, diabetes, dialysis, cardiac bypass, defibrillators. And countless times my wife was brought in at door's death, and countless times Dr. Goldhaber and Ruth Morrison, after some time, would send her home. She lived long enough to marry off our 3 kids and see 9 grandchildren. And without the efforts of the BWH, Dr. Goldhaber, none of this could have been possible. And so today, no matter what we say about Dr. Goldhaber, the BWH, and Ruth Morrison, honestly, it's never enough. And I want to thank, and I know Dr. Goldhaber, and I want to take this public opportunity to thank him for everything he has done for my family and me and my wife, and we've been able to hold it all together, and Sam played a great part in that. Thank you.
Yeah, thank you, Judge. We missed your wife. Ruth, I would like you to come up because you work so closely with me, taking care of many of the panelists. I'd love to get your input and perspective. And we've heard a lot in the panel discussion about how important the nurse role is. Maybe you could also address that.
Well, I just love listening to all of you people here today and your stories. And we do actually care about you all as much as you say that we do. And I think it's part of the job we love, is seeing patients. It's also great to see the people here from the Pulmonary Embolism Support Group, which we've known for years. And it's great to see them come back over and over again. And I just want to say that I think, as far as my job with Dr. Goldhaber, this is the best part of my job. Thank you. Oh, and yours too.
So now we have a chance for any here to come to the microphone and ask questions or make comments. I'm sure a lot of these stories must resonate in very strong ways. Any questions for the panel or comments? And do the panelists want to ask each other questions or comments? Because there are several themes here that do keep coming up. I think one of them, for sure, is how much more work we have to do in NATF. Our agenda, Caroline, becomes all the greater because we have some wonderful ideas here that need to be developed and funded, and a lot of challenges ahead. And it really is, I'm struck that we have a very sophisticated group of panelists, and to hear some of the stories is more than a bit surprising. Yes.
Dr. Goldhaber, Kurt Mahan from Albuquerque, New Mexico. A question really more to you is day surgeries with our shortening length of stay, and that being a kind of an area that may be a good opportunity to really risk assess or prophylax patients better. How do you really foresee getting into that area in the future and helping hospitals improve? The young gentleman kind of made me think about that kind of scenario.
Yeah, great question. I've been thinking about that as I've been absorbing what the panelists said. I like Charles's idea that everyone gets a written sheet, no matter how minor it is, because I think although the majority of those here today have smartphones and are very savvy with iPads and iPods, I think, Charles, you serve professionally a large clientele that is not, and links to websites aren't going to do a lot of people. It's not going to be enough for them. So I think, go ahead.
We've tried that with the CDs, and we've done studies and professional studies by PR firms and things like that because we advertise. And the numbers really shocked everybody that 70% of our client base does not use the internet at all. Can't get to it. I mean, again, in rural parts of the country, there aren't public libraries that you can get to that have it, that's free. it's easy in Boston and New York and the big cities that you would assume all that, but in most of the country, I say most of the poorer parts of the country, which are rural, this is not available at all. It just is not an option. And those are the people that are underreported and receive worse treatment. I mean, there is no Brigham and Women's in Western Kentucky. And I mean, everyone in Boston is really incredibly lucky. And in New York, too, how great the medical care is if you have insurance. But in parts of the country where my clients are, they go to free clinics. And I'm amazed that they have so many doctors who volunteer, but they go to free clinics because there is no other place. Or they see, no one sees a doctor in parts of the country anymore. They see nurses only. They don't even see physician's assistants. They see practical nurses, and that's the doctor. And even I see advertisement in small towns where people advertise medical care, and it's the nurse. So things have really changed, and it's very, very different from being here and being lucky enough to be, as everyone on this panel just about is, a patient of Dr. Goldhaber. I'm thrilled that Dr. Goldhaber is my doctor, but most people in this country are not going to get a doctor of that caliber. There aren't many of them, but in parts of the country, there are none of them. I mean, there are 2 orthopedic board-certified doctors in orthopedics in South Dakota. 2.
So, yes, Judge. Go ahead.
If I can, isn't the solution the mass media? The public airways and the TV and media, they belong to the public. Isn't there a duty among these cable, as a condition to licensing, that they make this information? Everyone has cable, everyone has TV. If they don't have an internet, they do have TV.
That's true.
And that's what we have to work on.
Well, that would be one way about public service announcements, which are very effective, but having done something like that, I tell you, you have no idea how hard it is to get a station to do it. For your particular group, as opposed to all the other groups, it's really, really hard.
Well, one observation I'll make is Ruth and I have cared for many individuals with multiple advanced degrees who never heard of pulmonary embolism. These are people who have multiple iPads and iPods and 6 or 7 TVs scattered around the house, and have not, still in 2011, never heard of pulmonary embolism.
How do you deal with the cost of the medication with these new anticoagulants out there? $240 for Dibadratran and versus $4. What can the government do? I mean, is there a government obligation? Do we have an obligation to make sure that that medication reaches the people? I mean,
$240 is if you have zero insurance. And I think, in all fairness, most of the insurance companies are rapidly improving. Nevertheless, the co-pays for all the new anticoagulants that I discussed tower over the full pay amount of warfarin, and I think that's why it's important that NATF have a public policy committee, and that which Dr. Kessler is chairing. And I think that's why it's important NATF has an advocacy committee, because as these anticoagulants come on market, and as they get approved for more indications, such as DVT and pulmonary embolism, hopefully we'll create a fair and just way to allow these drugs to get to the people who need them. Ted, did you want to?
Just on the education front, before I had my PE, my daughter was hit by a car as a pedestrian and severely injured, multiple broken bones, and a spleen that they were concerned about in terms of internal injuries. And they put a filter in her leg. Now, as you know, her father, I sat back and just sort of in horror at the scope of the injuries. But the thing that, in retrospect concerns me, and this is all about education. I mean, how do we learn? We learn through education, right? And so when I realized that, you know, she had this filter in her and that they could not hang heparin because the potential for internal bleeding, et cetera, I probably would have asked about 100 more questions of the attending doctors, but even more so since she had to spend a lot of time in a wheelchair and then, you know, immobile, if you will, flat in a bed afterwards. I think the only thing that we could rely on was the filter in retrospect, but I didn't know any of that stuff until I had my own PE, and then I found out through Dr. Goldhaber just what some of the causes of these things are. And again, it's all about education, really, more than anything else.
And I think additionally, it's not, I mean, this is just a multifaceted...
Could you speak more into the mic?
Sorry, this is just a multifaceted problem, and NATF has, it can't be solved with just videos or ads or whatever. Sure, that heightens awareness, but I remember being on a plane to Italy, and I was so happy that in the, you know, before you take off, they show you all these videos of how to fasten your seatbelts, and they also had a video about preventing deep vein thrombosis. And I was so proud, I was so happy that, wow, this is the first time I've seen it. This is great. It said, walk around the cabin and, you know, don't, and I remember getting up during the flight and the stewardess said, sit down. You can't walk here, you know, and I swear if I wasn't 35,000 feet up in the air, I would have told her to call Sam and Ruth, you know. So, but that goes back to the patient advocacy. I don't think we're ever going to get away from that. And maybe we shouldn't get away from that. Because what I said to the stewardess is, wait a minute, didn't you watch the video? And I had a PE, I'm walking around. And that was fine with her after that. So I think as much as we need education, as much as we need the publicity, we also need to keep instilling in the patients that you got to take, like Paul said, you got to take care of yourself. And I think as much as NATF is doing the publicity and whatever, it also should continue to stress that you got to take care of yourself.
So I guess we can take these reflections to answer Kurt's question and say, number one, for day surgery, because that was the question, what do you do with day surgery? Number one, you send the patient out with some written instruction that pulmonary embolism and DVT are risk factors. I think number two, we, and perhaps this is another NATF activity, need to come up with some form of surveillance or maybe questionnaire to the patient a week later, because you're at risk for a DVT for the next month or two after surgery. And it really doesn't matter whether you have your gallbladder out laparoscopically or through a large incision. There's still the risk because there is trauma, and that's a risk factor, and there's still some immobilization. And perhaps we need a more organized system to deal with follow-up surveillance, just like we talked about how important post-marketing surveillance will be for the new anticoagulants that are coming on the market. I think for the patient that Kurt asked about who goes home after day surgery, and I think day surgery is going to become more and more common, we need to come up with ideas to execute some standardized surveillance. Yes?
I have a question and suggestion is that to bring some awareness and education, where is Serena Williams? Is she here? I mean, come on, she is a massive female athlete that had a PE. And then you lead it, once you get people finding out that this isn't something that's in an exclusive group, suddenly everybody you know knows someone who's had a PE or DVT. So, you know, reaching out to someone like Serena Williams, has she been on Capitol Hill in front of Congress yet? You know, Dennis Quaid was for heparin.
Right. Right. No, I think getting well-known figures to tell their story is very useful. We had a very large fundraising dinner with Terry Francona, manager of the Boston Red Sox, who told his personal story about having suffered 2 separate episodes of pulmonary embolism. And that same evening, I think what really caught the attention of those who were at the dinner at the same time, we had a young lady from Brookline High School at age 16 talk about her massive DVT and how that kept her from continuing as a varsity sports player. And, you know, at the end of the evening, a lot of the feedback I received is that her story about how that affected her life and her very positive outlook was at least equally, if not more, captivating to everyone. Again, showing that that pulmonary embolism and DVT don't respect ages at any part of the age spectrum. Rajan, you started off. Do you want to? What are your thoughts now as you hear the stories of others in the panel, some of whom are one or more multiples of age of you?
Well, I can empathize with all of you, and I'm surprised that a lot of you could have had more than one. I mean, it's really shocking, and I feel that we should spread the word to everyone possible to try and get this awareness raised, see what we can do about it.
Thank you. Okay, any further comments from the panel members? Okay, I want to thank the patient panel. Well, now we've heard from our patient panel, and we've really spent the day starting off with a lot of didactic lectures on epidemiology and various aspects of venous thromboembolism, antiplatelet therapy. We spent a lot of time talking about the patient, and heard of the nurse, the physician patient, the nurse patient, and it's a lot of food for thought. And as we wrap up and conclude, I would like us to go home and think about how we can take the learnings from today and become involved if we're not involved, and stay involved over the course of this next year. And we can stay involved in many ways. We have the website of NATF to keep us involved. We have the telephone, the possibility of video conferencing, the opportunity to work in a meaningful way on one of the 5 working groups, to write articles or submit videos for our e-thrombosis journal, and to let our friends and family and colleagues know about NATF and the work we're doing. I think we have reached some new records here in terms of the registrants and participants in today's meeting, and we have really launched a plan, a strategic plan with infrastructure that is going to serve us well for the next decade. So stay in touch, enjoy the rest of the weekend, and we'll see you back again for our next live course in April.